Wow, what a great crowd. What a beautiful audience, beautiful day. Except, of course, for the residents who have to leave here and go work a shift after this. Not so much because it's a long day, but really because you have to take sign out from your attendings, right? And I'll let you in on a little secret here. It's not that we can't get better sign out to you. Oh, that's the end of the sentence. That's the end of the thought right there. Yeah, it's just that we don't wanna, so we're not gonna. And actually, after this little thing, if one of you wouldn't mind going into room 9, putting in a couple ultrasound guided IVs, 25 needs a rectal exam and a pelvic exam for some reason, and I got 3 admissions I need you to call in if you don't mind. Yeah, the workout's been done for hours. I just don't know how to call the admission in. Does it still involve a fax machine? Is that how you make that work? So it's great to be talking again at Resuscitation. It's been a while. I'm actually surprised I got an invite back after my last foray on social media, trying to do a little medical education. So Haney Malamet and I did a quick video on tips and tricks with video laryngoscopy. I didn't call him Haney Malamet Internet Personality, by the way. That's what his name comes up when you Google him these days. Not Haney Malamet MD or Doctor, Internet Personality. Jesus Christ, Haney. Anyway, so me and Internet Personality Haney Malamet did a couple of tips and tricks on video laryngoscopy, and let's just say the feedback was mixed. It was mixed. I'm going to share with you now some of the feedback on Instagram, some of my favorites. Bye-bye teeth. I like it. Short, to the point. I can get with that. And he lost all the teeth with the glide scope on the way in. Laughing, crying face. Man, that really stings. And then my personal favorite, RIP mannequin teeth. Fantastic. You know, if I had known, who would have thought? 3 years of residency, 15 years of medical education, teaching residents how to intubate, and I get ripped up comprehensively by some guy on the internet by the name of Jesse Me Rollin', which is apparently, I guess, a meme name in reference to the 2005 Chamillionaire hit, Ryden. There he is. And as if I couldn't feel any worse, I suddenly realized that in 2005, most of the people in this room were in kindergarten. So great. Maybe it's not that bad, though. Maybe it's not that bad. Maybe you guys know the song. We're going to try something, get you guys warmed up a little bit here, okay? Here's what we're going to do. I am going to rap the first line of that song. And then you guys are all going to jump in with the second line. And if you know it, then maybe I won't feel so bad like I'm ancient. Okay, so hopefully you know the song. Ryden, Chamillionaire, 2005. I'm going to substitute Jesse Me Rolling in for the first line, though. All right, you guys ready? You guys are emergency medicine doctors. You better belt it out. All right, here we go. You ready? Just see me rolling. I mean, it's not bad, but really at the end of the day, terrible, just terrible. Just when I thought I couldn't be any more disappointed in emergency medicine residents, you know? Bad news for Chamillionaire fans out there. He's not doing so well these days. In fact, he's been legally forced to change his name to 100 Air, which is unfortunate for him. Really? No? That didn't do it for you? 100 Air? Okay. So in response to all the anesthesia folk who keep tearing me up on the internet, okay, it's not like there are all these people roaming around South Jersey like a horde of zombies from The Walking Dead looking for their missing front teeth, okay? There aren't like thousands of people like, where's my front teeth? No, it's not like that. The real number is more like a couple dozen. All right, so what are we talking about again? Right, intubation of the neurological injury. I knew I've got some content in here. So here is my simplified model of brain injured patients. You get a brain injury, a bleed, a trauma, something like that. Part of the brain is dead. It's gone. Nothing you could do. Dead in seconds, minutes, not salvageable. And then there's a portion of the brain around there that is salvageable, but very vulnerable. Okay, and the stuff that you do in the emergency department, including around intubation, matters to salvage that piece of the brain. I'm going to talk about 3 things and 3 things only that you can do in your emergency department today to improve outcomes in these patients. We're going to talk about oxygen. We're going to talk about carbon dioxide. And then we're going to talk about medications to use during intubation and their effects on ICP and cerebral perfusion pressure. Here's the short form. Oxygen, keep it roughly normal. CO2, keep it normal to low normal. And the drugs? Nobody really knows. So that's pretty much the talk. If you guys just want to, go on your phones now and swipe left on Tinder or Grindr or whatever you want to do, that's fine, because the rest of the talk is me just trying to prove this stuff to you. This is my first AI image generator, by the way. I was going for like a Goldilocks, too hot, too cold porridge kind of thing. It's probably the worst AI image I've ever seen. When I look at this, all I see is a furry that looks like Dr. Michael J. Scott. It's the same face. It clearly is the same face. All right, let's talk about oxygen. As it turns out, exposure to low oxygen and high oxygen is bad in neurologically injured patients. Here are some studies to prove it. I don't want to put the studies up there. That looks dumb. So if you guys want to take a snapshot of this real quick, look it up later, that's fine. Anyone? Nerd. That's what my 9-year-old does to me whenever I talk about my day. So there aren't really great RCTs looking at this. It's not like you can intentionally expose a patient to severe hypoxemia and look at the outcomes. There's only one RCT that I could find where they trialed hypoxemia in brain-injured patients. It turned out pretty much as you would expect. This is hot off the press. You guys probably haven't seen this one. It was published in my favorite journal, the New England Journal of Totally Obvious Medicine. It was a dual outcome trial. They were looking at fire and oxygen, and it turns out hypoxemia and fire bad for the patient. So how do we avoid hypoxemia in these patients? This is a whole talk I did in Resuscitation a couple years ago. I'm going to break it down quickly for you here. Here's 3 tips for you. So I call them the 3 Ps: pre-oxygenation, positioning, and putting the tube in right the first time. That one's a little forced, but we'll work with it. So in terms of oxygenation, you've got a plethora of devices to choose from. I've kind of been banging this drum for many years, and it finally was kind of proven with a big New England Journal trial. But probably the best method to avoid hypoxemia in these patients is pre-oxygen with non-invasive positive pressure. That is BiPAP or CPAP. It's a tight-fitting mask, 100% FiO2. You probably recruit some areas of the lungs by forcing the airways open that weren't otherwise available to store oxygen. And this is a 1,200-person trial that finally proved it. We've kind of known this for like a decade. There were lots of smaller studies, anesthesia studies that kind of showed this. And this is kind of, I think, the nail in the coffin. Now, that is sometimes a little difficult to set up. Most modern ventilators can do this, so you can just bring down the ventilator. And at Cooper, you can't because they said they need like a $10 piece of plastic elbow to connect to the mask. And that was 6 months ago. And I haven't seen that goddamn $12 piece of plastic yet. So you have to call the RT and like, yeah, man, can you bring down like the BiPAP setup and a ventilator? And they're like, what are you talking about, man? You got to pick one. I'm like, nah, it's cool. Just bring them both down. And they don't want to do that. So in a pinch, and if the ortho patient's not really hypoxemic, they're 100% on room air and you're intubating for airway protection, you can use this guy. This is the old standby when I was a resident, 2007. This is what we did. Put the mask on, cranked it to 15 liters, and that's how we pre-oxed. So more modern methods, it's usually the same thing, but instead of putting the wall monitor to 15 liters per minute, realize that wall monitor can actually generate a much higher flow rate. You can crank it open and get flow rates more like 35, 40 liters per minute. And that increased flow is thought to provide a better FiO2. You'll know you've hit it when the monitor makes an alarming sound. That's how you know you've hit flush rate oxygen if you didn't know. All right, so in smaller trials, again, this is not a big RCT. They're looking at surrogate measures, kind of like they'll pre-ox people with a bunch of different methods. And then the flush rate non-rebreather at the end of that period of pre-oxygenation in healthy volunteers, they exhale more oxygen than by the other methods. All right, so that's kind of like a roundabout way of saying it's probably better than standard BVM or non-rebreather for pre-ox. Okay, let's talk about positioning. Positioning. Oh, that's the wrong slide. That shouldn't be in there. That's from a different talk that I do. Okay, stop laying patients flat. Why are we doing this? It's bad for many reasons. Okay, not just for pre-ox. It's bad for them to vomit up into their airway. All right. It's bad for direct laryngoscopy because you have a really acute angle to get around. So leaving them ramped or sitting up for pre-ox and then ramped for intubation is probably the way to go. Now think about it. When's the last time a patient in severe respiratory distress rolled through the doors of the ED and they're laying flat on their back? No, they're always sitting up and kind of leaning forward because their body knows that's the best way to get oxygen in. When you lay flat in your back, especially in obese patients, but even in non-obese patients, the weight of the chest is pushing down on you. You've got the abdomen pushing up against the diaphragms. It prevents full excursion of the lungs, which means some pieces of the lung get kind of smushed. They get smushed. Haney would call it de-recruitment, but that sounds kind of fancy for us, right? I call it smushed lung, atelectasis, whatever you want to call it. Those pieces of the lung now are not available to store oxygen. Less oxygen stored means you have a shorter, safe apneic time. That patient will desat quicker. You don't have as much time to get the tube in. So sit them up. I sit them up close to 90 degrees. If they're obtunded and they're kind of slumping over, then more like 70 degrees. And I leave them like that until we push the meds, and then we'll lay them down into a ramped position for intubation. If you're wondering, Dr. Byrne, by how much force is taken off the chest when we put the patient on a ramped incline, the answer is pretty obviously mg cosine theta. I think that's pretty clear, and you guys knew that, right? Bad news if you did know the answer to that question. Statistically speaking, if you know the answer to that, you're going to die alone. You're never going to find anyone. If no one told you before, I'm glad that I could be the one to tell you now so that you can plan your life accordingly, but you're probably going to die alone. Okay. Putting the tube in the first time. Probably not the best airway in a neurologically injured patient, especially at risk for hypoxemia, for a brand new intern to take that tube. All right? If you're unfamiliar with what a wild new intern in the wild looks like, I got a couple of tips for you. Note the blank, vacuous expression, the terror behind the eyes, the mouth hanging open, laryngoscope in the wrong hand and backwards. Knees weak, arms are heavy. Was vomit on the scrubs already, mom spaghetti. Yeah, no, that was 2002. Right, but it looks like pre-kindergarten for you guys. Okay, and notice that he has his badge turned around. I guess he didn't want people to know who he was, but I ain't having that. So there he is. Hi, Austin. There he is, right here, front row center. Thanks, Austin. Appreciate the photo. Now, neither probably, to be fair to Austin, you probably also don't want the attending intubating who's pushing 60, you know? They haven't intubated in a long time. This is the vice chair of emergency medicine at Cooper. He's the guy who figures out how big my bonus check is every year, so I thought he's a good one to make fun of in front of a large crowd. Here I am like, what's this guy doing? What am I going to do with this guy? Anyway, you probably don't want the person managing the airway when their last intubation was during the Bush administration. No, that ain't it. There it is. Okay. My last tip for getting the tube in the first time, use a video laryngoscope. Use a video laryngoscope. Use a video laryngoscope. These been around for like over a decade. I yell about it in every airway talk I do. No one listens to me. The residents are like, nah, it's cool, man. I don't need a crutch. Okay. Or if they use it, they like turn the screen around. They're like, I'm going to show what a big, strong man I am. I don't need that. And I'm going with my really strong bicep and a Mac 3. That's all I need. Okay, fine. Turn the screen around if you want, but use a video laryngoscope. It's clear that first pass success is better in pretty much all levels of training and experience. Okay. So if you want to turn the screen around, that's fine. This is the final kind of nail in the coffin after a decade of smaller studies. Big randomized controlled trial in critically ill patients. Video laryngoscopy got the tube in the first time better than non-video laryngoscopy. Okay, critical in these patients to avoid hypoxemia. Exposure to hypoxemia, again, correlates with badness, including mortality. You need to avoid it at all costs. All right. I said that hyperoxia is bad too, and that's true. Exposure to too much oxygen is also bad. So once you get these patients intubated and on the ventilator, immediately titrate down that FiO2. Even exposure to hyperoxia. We don't know clearly what the time frame is, like you have to be exposed for like an hour or a couple minutes. Unclear. Most of this data, again, is retrospective. They pulled random ABGs, and patients who had very high oxygen did worse than patients who had normoxia. But at any rate, it's probably prudent to turn down the FiO2 as quickly as you can. You want to titrate it to about a pulse ox of 96%, which correlates roughly with a PaO2 around 100. That's your target. So my suggestion is get the ventilator hooked up, walk over to the vent, and start fiddling with the knobs and pushing random buttons until the FiO2 goes down. If it starts making a horrible screeching noise, don't panic. Alarms are going off. You don't know what those alarms are doing, okay? This is what you do. Do what I do. First, you look around. Did anyone see you messing with the ventilator? If the answer is yes, choke them out. Real quick, just shh, go to sleep, go to sleep. Then back slowly out of the room and run to the bathroom until things die down. That's what I do. So turn down the FiO2. Okay, moving on to CO2. This is also a thing that matters. So again, exposure to too much CO2 and too little CO2, just like oxygen, correlates with poor outcomes in neurologically injured patients, including mortality. So they die more frequently. Quick primer on CO2. If you drive the CO2 down, the pH goes up. pH goes up too much, that's bad for the brain. No one likes alkalemia. You get cerebral vasoconstriction, which can decrease the ICP. And for a long time, this was thought to be one of the primary ways you can control ICP in these patients. Hyperventilate them, decrease blood flow to the brain, ICP goes down. Obviously, that's a little bit of a problem because if you vasoconstrict too much, you get decreased blood flow to the brain, and all those vulnerable areas of the brain need blood flow. They need glucose, they need oxygen. So too much is probably bad, and it is bad. How about too much CO2? pH goes down, no one likes acidemia, especially injured brain cells, they don't like that either. Cerebral vasodilation occurs, which means your ICP goes up, also bad. So what's the right answer? Somewhere around 35 to 40. That's what the Brain Trauma Foundation came up with. 35 to 40 is a good target. Hyperventilation to lower than this is only recommended in extreme circumstances, like in neuro ICUs with continuous oxygen monitoring, which we don't do. So when I saw this, I got excited. I said, wow, I've got an idea. Because it takes a while to get a blood gas back, right? And we don't want even exposure to this to happen. So maybe we can use end-tidal, connect it to the endotracheal tube, monitor it, get continuous waveform capnography, and get an end-tidal CO2, and use that to more quickly titrate the CO2. And I thought, this is gonna change everything. I'm gonna be famous. And then it turns out this is already a thing. Of course, every idea I have is already stolen. So they use this in various settings. It was shown for paramedics intubating brain-injured patients. They use this to help prevent hyperventilation, which again we know is bad. So that is a thing. And it's a couple trials in the emergency department too, where it does correlate fairly well with your PaCO2. There's like an 18-page article on EMCrit about it. And I was like, oh man, this has already been done. If you want to read it, if you don't want to read it, they say, good, it's a good thing to do. You do want to target an end-tidal CO2 slightly lower than your PaCO2 target because it does underestimate the PaCO2. So your target on the end-tidal on the monitor is more like 30, okay? Because it underestimates by about 5 to 10. So target 30 on the end-tidal. When I came up with this idea originally and didn't realize it was already a thing, I texted my good friend and internet personality, Haney Malamet, and I said, Haney, you guys doing this in the ICU? I've got a great idea. And his reply was, of course, lols. Thought the lols was a little unnecessary, Haney, you know? Make me feel bad all the time. R.I.P. mannequin teeth? Oh, Haney. Oh, quoting my arch nemesis, Just See Me Rollin'. Brutal. Brutal takedown. So drugs. You can't do a talk on this kind of thing without talking about the drugs. This was always a hot topic, even when I was a resident. We were taught, for example, to avoid succinylcholine because in small animal models, where they're monitoring the ICP, giving succinylcholine caused the ICP to rise a little bit. So they said, don't use succinylcholine. And then they tried to do all kinds of crazy things to let you use it, like giving a small dose of sux and then a bigger dose so that you don't go like this. And maybe that'll blunt the ICP effect. And then other studies came out that said, you know what? That was probably all wrong. Succinylcholine is probably fine. And then lots of studies over the decades looking at sux versus rock. And despite all the opinions out there, really no convincing evidence that one is better than the other. Okay, so at the end of the day, it's kind of a wash. Here's one study that came out recently in JAMA that really showed no difference in all the things we care about: hypoxemia, hypotension, or peri-intubation cardiac arrest. And in fact, all the kind of meta-analyses and Cochrane reviews that looked at this basically found no meaningful difference. The only thing that they found is that sux gives you a better intubating conditions, is what they said. Better intubating conditions. I'm not even really sure what that means. Okay, so at the end of the day, you can pick which one you want to use. The one caveat I would say is that if you do choose rocuronium, remember they're going to be paralyzed. And many patients, when they're paralyzed and they don't get adequate sedation, wake up paralyzed. And when you wake up paralyzed, it's kind of disconcerting, I'm sure terrifying. People get PTSD and all that kind of thing. And pretty reliably, they're going to start freaking out and their blood pressure is going to spike through the freaking roof. And you don't want that in neurologically injured patients because that's going to drive up the ICP, make your hemorrhage bigger or whatever. So if you do choose rocuronium, make sure to sedate those patients really well and avoid this complication. How about your induction agents? Okay, one thing I would say is just avoid things that will drop the blood pressure unpredictably. So things like propofol are probably not good in intracranial hemorrhage and traumatic patients because it will, on average, drop your blood pressure by about 20%, but it's kind of unpredictable and you can't really titrate it with a big bolus. All right, so avoid agents that cause hypotension. Etomidate and ketamine are probably our most popular. And there have been lots of studies looking at these head-to-head. And as it turns out, at least in severe traumatic brain injury patients, there's really no difference in the outcomes that we care about. So if you love one versus the other, that's probably fine. Ketamine, again, when I was an intern, was a no-no because of small trials that said it does increase the ICP. And then other trials said it doesn't increase the ICP. It's really exhausting, you know? Like everything you guys learn is going to be wrong in 10 years, all right? So at the end of the day, pick whatever agent you want. So in summary, oxygen, keep it around 100 to 200 PaO2. All right, avoid hypoxemia at all costs via the methods we talked about. Avoid hyperoxia, adjust that ventilator as quickly as you can. Use the CO2 almost like a medication and titrate it. Try to get it around 35 to 40. Consider using end-tidal to get a better estimate early of what your real PaCO2 is. And when it comes to drugs, I don't know. People have a lot of opinions, but I haven't seen any hard data to suggest that one is better or worse than the other when it comes to brain injured patients. And that's it. Thank you very much for your time. It's been great. See you again in a couple of years, hopefully, maybe.